resource team, and we're very excited to have our clinical Lunch and Learn webinar for the month of September on assessing adolescent substance use disorders. Julie Gutowski, who is the Managing Director of Clinical Services at Spectrum Human Services, is going to do a wonderful job of really taking us through both understanding what substance use disorders are among adolescents, diagnosis, assessment, and some treatment options, and really kind of ways of thinking about applying some of those tools and resources in your work with clients. Some quick housekeeping before we get started. The webinar you will be able to hear primarily through the phone, or if you have speakers on your computer. If for some reason you're not hearing audio, hopefully you'll be able to call in. If you're having any technical challenges, you can email our host through the chat box, or send a chat through the chat box to our host, and she will try to attend to any of those technical challenges. All participants are going to be muted, and if you have any questions, you can use the chat box and send to all panelists. The chat box is on the bottom right-hand side of your screen, and you can click send to all panelists if you have any questions about the content. We're also going to have a short Q&A at the end. At least once or twice throughout today's webinar, we're going to ask you either a polling question or ask you to respond to a specific question through your chat box. And again, you can keep using that panel on the right-hand side of your screen to submit to all panelists. So I'm very excited to introduce Julie. Julie, would you like to tell us a little bit more about yourself and go through the agenda?
Sure, thanks, Lydia. My name is Julie Gutowski. I'm Managing Director of Clinical Operations at a large not-for-profit behavioral health provider in Western New York. I'm both a licensed mental health counselor and a CASAC, which is a credentialed substance abuse counselor. I have been in the field for approximately, it's going on 13 years, of which that time I've really devoted myself to focusing on the treatment of co-occurring disorders and also the treatment of co-occurring disorders with adolescents. So for me, on a personal note, when we were creating this webinar, my main goal was that you would be able to come away from the webinar, not that you're going to be a guru in the treatment of co-occurring disorders for adolescents, but my hope is that what you'll be able to have is some confidence and the thought that, hey, I can do this, that it's important for me to look at and assess and treat for a co-occurring disorder in an adolescent, and hopefully to give you some real-life skills and tips, tricks that you can use while you're working with adolescents. So our agenda today includes diagnosis, really talking about a little bit, and we're going to give you as a resource for the PowerPoint, it has the diagnostic listing for substance abuse and substance dependence. We're not going to spend a lot of time going through that because I think that's all information that you guys have and we're giving it to you so you could print it out if you needed it. But really what we wanted to talk about is the screening and assessment. How do you do a good screening and an assessment? And after you do a nice thorough screening and assessment if needed, how do you figure out what treatment options and what interventions you should be providing that might be helpful for the person? We're also going to talk a little bit about next steps and then have a few minutes for questions and answers.
So, and I also want to add to what Julie just said is that the slides as well as the recording for today's webinar is going to be posted on our ctechny.com website. So you will have all these materials as well. So before we get started, we wanted to ask a polling question. So if you'll see on the right-hand side, a polling kind of panel would have popped up. How often do you see a client, so in this case, the adolescent client who uses substances? And if you could just take a couple seconds to click your answer, either all of the time, this is something you see constantly, you see a case who uses substances some of the time, or it's something you really don't see. If you can just take a second to really click an answer, and if everybody could take a second to respond, that would be really wonderful, and we can kind of understand where everybody's starting. And once we have enough responses, we can kind of click over and see the results. Okay, we could probably see the results right now. Sometimes it takes a second for it to come up. And you'll see the results are going to pop up on the right-hand side as well, so you get a feel for what others are experiencing. Okay. So it seems that very few of you don't have any clients with substance use issues. And of those that were able to respond, most of you seem to have them at least some of the time. So some of your cases are experiencing some of these co-occurring disorders. And there's actually a few of you who also see it all the time. So it's a bulk of your caseloads. Thank you, everybody, for taking the time to respond to that polling question. So now Julie will get started with her presentation on co-occurring disorders.
Thank you. What I wanted to start by is talking a little bit about the context about why it's important for you to be participating in this webinar and how it's important for you to develop your skills related to the treatment of co-occurring disorders for adolescents. Research has shown us that disruptive behavior disorders and mood disorders are associated highly with substance use disorders. I don't think any of this information is going to be surprising to any of you who work with the children. The children and adolescents we see oftentimes have multiple problems, limited resources, and limited supports. It's also important to recognize really the co-occurring rates of PTSD and substance use disorders can range from 25% to 75% for the youth that we are seeing. So it's really important to understand that if somebody is coming into clinic and they have a multitude of problems related to mental health, it's important for us to look at whether there is a co-occurring disorder, because a lot of times what happens is one of our adolescents we're working with has a lot of anxiety or depression or post-traumatic stress disorder symptoms, and they start using substances as a way to kind of deal with or self-medicate the mental health symptoms. So it's really important for us to be able to look at and kind of tease that out to see really is there a co-occurring disorder or not. Realistically, the best treatment that we can provide to the adolescents we're working with is integrated treatment. And what I mean by that is in the past we've had these silos, and the silos would be I'm the mental health therapist, and so I don't address the substance use. I can either not address it because I don't think it's a concern, or if I think it's a serious concern, I'll refer the person to substance use treatment services through somebody else. The issue is that the silos aren't helpful for the individuals we work with, and I think a lot of times it also makes the work that we want to do with the adolescents more challenging, because if I'm not able to address the marijuana use or the alcohol use, in addition with the symptoms of depression or ADHD or anxiety, really I'm only treating one problem and I'm not treating both issues, and so a lot of times it feels very fragmented and it's hard to make any kind of progress. So again, as I said, one of the main goals we had was for when you finish with this webinar that you have the sense that I can do this and I'm interested in trying to integrate some of this into my current practice. It's really important when you're assessing and treating substance use disorders to start with a screening tool. And really what a screening tool is, obviously, is it gives you a quick snapshot about whether or not you need to dig a little bit deeper. If the screening tool indicates that there is a potential problem, that's when you would do a more comprehensive and thorough assessment. And now what I'm going to do is I'm going to give and say a very controversial statement. A lot of people have feelings when I say this, and I say it with the utmost respect for all of the work that we do in clinic. But the reality is when you're treating a substance use disorder, and that it applies for adolescents with co-occurring disorders as well, one of the most effective clinical interventions is the BAC and the urine toxicology testing. And I want to just spend a few minutes and talk about the therapeutic value of substance use testing. A lot of times in mental health, we have 13 clinics in Western New York, and we provide co-occurring treatment at each clinic. And sometimes people feel uncomfortable with the idea of giving a urine tox. And I can understand that a little bit. It may be a newer concept in mental health clinic, but the reality is testing can be a significant part of the treatment process. Somebody has said to me before, I don't want to do urine testing because it's punitive. And I really didn't understand what the person meant when they said that, what the clinician meant, and I thought more about it, because that never in my head occurred to me that doing urine testing or BIC is punitive, because to me it's just another way that I gather data and information so I can make informed choices and help the individual I'm working with make informed choices. It's a measure. So if you don't have the ability to do a breathalyzer test, which is blowing into a tube and it's looking for alcohol in the person's breath, or if you don't have the ability to do a urine toxicology test, you may want to work with clinic leadership to figure out how that could happen on site. And if it can't happen on site, what you also want to do is think about what are some creative ways. Can you ask the person to go to their pediatrician and get a urine test? So for me, it's really important to look at that, and I really normalize that starting at the first session, that it's part of the process. It's not that I think that the person's using substances and hiding things from me. The reality is it's just another way I can gather information. And I wanted to talk a little bit about what is a substance use disorder. For me, I recognize, or I believe, that use oftentimes is a part and a typical part of the development process, okay? So just because somebody uses marijuana or alcohol and they happen to be 14 or 15, that does not mean to me they have a substance use disorder. Okay, I kind of see it as a continuum of use. It usually starts out as social and recreational, and then it can lead to abuse. It does not always lead to abuse, but it can. And abuse to me is the person is really having some problems associated or caused by their substance use, whether that's a drug or an alcohol. And then you move into dependence when that is an impaired control and they're not able to control their use and they have bigger problems. So for me, I kind of think of it as a snowball scenario. So I make a little bit of a snowball and I'm at the top of a very high hill. And so what happens is I'm about 5 feet away from the edge. So I have a snowball and I start to roll it a little bit. So for me, that's just like social recreational use. Now what happens is if I continue to roll it a little bit, it continues to get a little bit bigger and a little bit bigger. That's what's going to happen. If it goes over the hill, it's going to continue to get bigger and it's going to pick up speed and momentum. And so to me, that's like kind of like what happens. For me, that's how I conceptualize turning from typical use into abuse. It's a little snowball that kind of starts to pick up speed and momentum. At some point, if I'm hitting the snowball near the top of the hill, then what happens is it doesn't go all the way down, so then it kind of just stays the size it is. But if I'm unable to stop the use and the snowball continues to go down, it continues to pick up speed and momentum, and it continues to get bigger and bigger, and for me that is analogous to it continues to cause more and more problems in numerous life areas for the person, their use. And so I wanted to first start talking about diagnosing a substance use disorder and really the difference between abuse and dependence. And here is our diagnostic criteria for substance abuse. And I'm really not going to go into this. And for me, the big difference between abuse and dependence is the number of problems caused by the use and also the severity of problems caused by the use, for me, is how I can distinguish between abuse and dependence. And here is our criteria for substance dependence. I wanted to take a minute and talk about polysubstance abuse or dependence. And according to the DSM IV TR, you can use this diagnosis. Luckily, it's my preference not to use this diagnosis, and it's not available in the DSM V. For me, it is more helpful clinically to create a picture and understand what I should be doing treatment-wise, what is the prognosis for the person. If I specify instead of polysubstance abuse, that means the person is abusing more than one substance, is if somebody were to say to me cannabis abuse and alcohol abuse. Okay, the polysubstance abuse or dependence, it is a valid diagnostic criteria, but I think it leaves a lot to the imagination. It is way more helpful for me clinically for me to understand what is the level of the substance use disorder and what exact substances, because it makes a big difference in terms of clinical interventions, risk, and also prognosis. And so there are some screening tools recommended for use with adolescents. And again, for me, as part of the process, I start with a screening tool. And I like to screen all of my adolescents that we see in clinic, okay? Because it either screens them out, meaning I'm always going to kind of keep an eye open to see if something pops up, but it also tells me when I need to dig a little bit deeper. And so 2 screening tools that are recommended for use with adolescents, and I'll show them quickly. We have the simple screening instrument for alcohol and other drug abuse, and I'll show you that quickly. And then we have the CAGE aid, or AID. You notice the CAGE aid has the 2 stars next to it, because for me, that's a nice, quick and dirty screen that I don't need to remember 13 or 17 questions. It's 4 questions. So I want to show you real quick the SSI AOD. And so it's asking questions related to the past 6 months, okay? And it'll ask questions, have you ever felt that you used too much alcohol or drugs? Have you tried to cut down or quit using drugs? You answer yes or no, depending on what the score is. You would do a more thorough assessment after that. And so we have numerous questions here for that screen. The reason I like the CAGE is because I know it off the top of my head, because it's 4 questions basically. And CAGE stands for, have you ever thought about cutting down on your use or drinking? Okay, C for cut down. The next question, have people annoyed you by criticizing your use? A for annoyed. Okay, so that's why for me, I really prefer the CAGE. It's simple. It takes me less than 5 minutes to answer these questions, and it gives a good indicator as to whether I need to look a little bit deeper. And CAGE obviously is the abbreviation for the 4 questions that you're going to be using. That's why for me, it's really, I much prefer the CAGE because I know that like the back of my hand. I guess I could learn the other one, but I'd rather learn 4 questions than 13. And so here's some information related to the SSI AOD. 16 items, it's free. A couple questions aren't scored, 4 or more yes, that really you should do a more in-depth assessment. And here's the CAGE. It's rated very highly. It's basically the 4 items, and you can memorize that pretty quickly. And it's free. If the person answers yes to any of these questions, then you should really be looking at a more intense or more delve a little bit deeper into their use. Just because somebody answers 2 questions as yes on the CAGE doesn't mean they have a substance use disorder. What it means is I need to look a little closer. Okay, assessment and asking the right questions. So what I wanted to talk to you guys a little bit about is kind of how I frame things. So how do I go about gathering information about a person's use? In the first session, I always talk to people about what is my clinical style. My clinical style is all my cards are always on the table, and I'm just going to ask questions and see what happens, okay? And so really my opener is, tell me about your use. So if they use marijuana, I won't say, tell me about your marijuana use. What I try to do is I try to use their language, and I give a disclaimer at the first visit. I tell people, and I make a little bit of a joke. I say, oh yeah, you know, I know that, you know, you're only 15 and I'm like 100 years old, and, you know, but if you could give me a chance, you know, you might be able to teach me a few things, I might be able to teach you a few things. So in using their own language, I'm not trying to pretend I'm an adolescent or I'm 15 years old. I'm just trying to get them to understand that I really can relate to them. It's an engagement thing for me. If somebody says something and I don't know what they're talking about, I ask them. And a great example of this is I had one of my coworkers had a client, and they used a term, she was doing a health screening and he got burnt. And so she's like, what do you mean? She's a nurse, like a 3rd degree, a 2nd degree. He chuckled a little bit and he said, no, that means, you know, she gave me something, you know, like an STD. And so I thought it was really great that she had the courage to say, oh, yeah, I don't know what that means. And I think it can really help. And it's important if somebody uses a term you don't understand what it means, I ask them. And I always try to remain neutral about the use when I'm doing the assessment and the screening. I never make judgments about the person's use during the assessment and screening process, okay? I'm really trying to be open. I really want to know from their perspective what's happening. I'll give you a little anecdote. I was working with somebody, she was about 16, and she literally weighed maybe 100 pounds. And so I was asking her about her drinking because she drank beer, and she would say, you know, sometimes she drank between a 6 and a 12 pack a day. And now I'm looking at her, and I'm like, in my head thinking, well, that's a lot for somebody who's 100 pounds. So at that point, I didn't say, gee, you should be really concerned about, that's a lot of alcohol, you should be concerned about alcohol poisoning, or if you're doing that on a consistent basis, you should be worried about withdrawal symptoms. What I said to her is, okay, why don't you tell me a little bit more about that? And I think at one point she asked me during the assessment process, again, I am gathering information, I'm not giving information. She said, do you think that's a lot? And I said, well, I've heard people who've drank more than that, okay? What I'm saying with that is, at the end of the session, what I said is, let's talk a little bit about you drinking between a 6 and a 12 a day. It makes me a little nervous, and this is why. And then I went into, after I got all the information, after hopefully she felt some kind of connection, that I could give her information and education about, gee, you need to really be careful about those things. If I had started when she said, I drink a 6 to a 12 a day, and I said, wow, that's a lot. At that point, I think it really would have shut down, and I would have gotten far less information that I needed than me just saying, oh, okay, well, tell me a little bit more about your use. And then to me, what I really need to know when I'm doing the screen and the assessment is I need to know the substances that the person is using, and I really want to know the pattern. It's really important to know the amount, the frequency, and the duration. If we go back to my girl who drank a 6 and a 12 in a day, I would ask, well, when you say in a day, what does that really mean? Is that the whole day, or is that when you get home from school at 4 and you go to sleep at 9? Because there's a huge difference between those two things. So I really want to know the substances, the amount, the frequency, and the duration of them using. I want to know about any consequences that result from their use, okay? I don't say, well, what are the problems caused by your use? Because 9 times out of 10, what I'm going to get is none. What I'm going to do is when I'm asking questions, open-ended questions, and I'm trying to explore a little bit about their use, when they're saying things, I'm paying attention to what I'm picking up and what I'm paying attention to and what I'm responding to. I really want to know that adolescent's perception of the use. I also want to see, was there any time that he or she wanted to quit using, okay? Why I want to know that is, I've never tried to cut down. I drink probably about 8 to 10 bottles of water a day because it's good for me and it's healthy. I've never said to anybody, you know what I want to do? I want to cut down on the number of waters I'm drinking in a day, okay? You only cut down on things you think have a negative impact. So I'll ask, hey, have you ever thought about quitting, or have you ever tried to stop quitting? You know, have you ever tried to stop smoking? If they say yes, I say, tell me a little bit more about that. Why do you think maybe you should not drink so much? Why do you think maybe you shouldn't be messing with the pills anymore? And I'm getting their perspective about use. I'm also, in my head, gathering information to make a good assessment as to whether this is a substance use disorder or not. Anybody to me who's ever said they thought about quitting before, and that to me indicates they have some problems associated with their use. And then I really wanted to spend a little bit of time talking about asking the right questions for a substance abuse diagnosis. So really this is smaller problems caused by the use, okay? They may be able to control their use, but maybe their mom or dad are on them or their guardian because they're smoking weed or they're drinking. So some questions I ask and I'd want to know about is, have your friends changed in the last couple of years? I really want to know, does their social life involve around getting high or getting drunk or using substances? So here's some good questions. And again, for me, make the questions sound like they're coming and how you would say it. And that's one of the biggest pieces that I would have, is to take this information and figure out how it's going to work with you. And then, so what we did is we divided the diagnostic criteria for substance abuse and substance dependence. And then these are some questions you should ask about when you're doing a thorough assessment for substance use disorder. And again, I'm not going to go into all of these in depth because you can review them at a later date. We've also given you some information related to tolerance and withdrawal, and that's good to have. And so really what I want to ask you guys right now is, how do you currently treat an adolescent who has a co-occurring mental health and substance abuse disorder or substance use disorder, if at all? So if you could respond to that question in the chat box, that'd be great. And we basically want to know, if you're treating somebody with a co-occurring disorder, are you treating just the mental health symptoms? Are you treating the co-occurring disorder? Or are you treating the mental health symptoms and referring out for the substance use?
So just as a reminder, make sure to use the chat box on the right-hand side, type into the bottom blank box, and click Send to all panelists. And make sure you click that Send button, and then we'll see your response. So how do you currently treat an adolescent who has a co-occurring mental health and substance use disorder? And even if you don't, let's say these come by you and you don't, you refer them out, let us know as well. Okay, so far we got one response from Laura saying that they tend to just focus on the mental health and refer out for substance use disorders. So we're getting a lot of replies back around referring out to other substance use programs, treat co-occurring individually within the clinic, or integrate the treatment with outpatient referrals. So there's some of you that are able to treat to them together, or they've gone to a substance abuse program first and then they come to you for mental health issues, or you work or collaborate with a specific provider. So you coordinate your services with a substance abuse provider. But what I'm seeing, Julie, is a lot of referring out.
Right.
Or some occasionally are trying to attend to both or coordinate with an outside program.
Mm-hmm. And I think that's pretty typical of what happens right now in mental health clinics, that if somebody does have a substance use disorder and we're concerned about it, what happens is we have a tendency to refer to a treatment provider. In the best case scenario, the treatment provider is on site, but the problem is for you to find time to meet with that person's CD counselor, chemical dependency counselor, so you can discuss what's going on with the individual, rarely happens because you're busy and the other person's busy. And so what we're hoping to do is to give you some ideas about some things you should consider or could consider before you immediately do a referral out. And again, I want to talk a little bit, and thank you for all that, the answering to that question, because I think it's pretty accurate and consistent with what I've seen across clinics as well. A lot of I'll handle the mental health, and then either I'll refer out, or if somebody has some abstinence from chemical dependency, they've completed a program, or they have 30 days or 90 days abstinent, then I'll handle the mental health. And so I wanted to start with working with an adolescent who has a co-occurring disorder mental health clinic. Where do I start? And again, usually at some point in treatment when I'm working with the adolescent, I make a joke about that I'm about 100 and they're like, 15, but maybe we could teach each other something. Because for me, I want to get it out there that, I know that I'm not 15 years old, and I'm not an expert in their life, they are, but I kind of know a decent amount about substance use and mental health and how they go hand in hand. So when I'm looking at working with an adolescent with a co-occurring disorder, and I've done the screen and I've done a more thorough assessment, and so I have information, how do I start? How do I start to make the clinical decisions that I need to? Okay, the factors that I consider when I'm working with somebody who has a co-occurring disorder is I really look at the risk factors. Risk factors related to the substance, related to the pattern of use, and the impact on the mental health symptoms. So what I mean is, if I have somebody who's abusing heroin and they're using it IV daily, more than likely, I'm not going to address that substance use disorder in the context of the mental health clinic because we don't have the service mix and levels needed to appropriately address those concerns, okay? I also am looking at safety. I'm looking at the individual goals and what is the stage of the change that the individual is currently in. Okay, so individual goals. In chemical dependency, just so you know, whenever we refer somebody to chemical dependency and it's an 822 outpatient, which is where we typically refer, the goal in OASAS in an 822 chemical dependency clinic always has to be abstinence. It cannot be harm reduction. So if you have an adolescent you're working with and she doesn't want to stop smoking marijuana and you refer her to chemical dependency, what they're going to do is they're going to, pretty soon after admission, start talking to her about how she needs to stop using and what is the plan. So for me, that's one of the factors that I consider when I'm trying to figure out, am I going to treat this in-house or am I going to refer out, am I going to do a siloed treatment, okay? Really the risk factors related to substance, the risk factors related to pattern of use, risk factors related to impact on mental health, the safety, what is the person's goal, what does the person want to do? Do they see that problem? And really, what stage of change are they in? The things I also, in terms of for substance that I'm concerned about, I not only want to know what substance they're using, I'm also doing some assessments for actual or potential damage or consequences from use, and also the potential for withdrawal and whether there's a serious medical issue with withdrawal. Okay, so if somebody were abusing opiates, and we typically don't see heroin in mental health clinics. I think what we will see is we'll see the Oxys and the Loratabs and the Opana come in, and people are abusing those in mental health clinics adolescents, okay? I know enough about withdrawal from the different substances to know that if somebody were going to experience withdrawal, it's not medically, the person's going to be very uncomfortable, but there's not a huge medical risk. Now, if you have somebody who's abusing alcohol on a daily basis or somebody who's abusing benzos, you really are talking about withdrawal symptoms that can have some pretty significant physical health complications. So for me, you're going to really be thinking about those when you're making the decision. Am I treating this in-house? Do we have the services needed to treat this co-occurring disorder? Or do I need to look at referring and to where? So for me, what I wanted to start with in making all of that and doing the assessment and the screen and also providing the treatment, how do I make all that work in the context of mental health clinic? And for me, I do that through the stages of change in motivational interviewing. And when we were putting the slides together, oh, sorry, I am not saying to silo treatment. I saw that somebody sent that in. What I'm saying in certain cases, if I had somebody come into mental health clinic, an adolescent, who was using IV substances, I would provide a referral to a treatment facility for chemical dependency that could potentially address both, because realistically in chemical dependency world, if somebody comes in and they may be referred to inpatient treatment, what I need to do is I need to increase my level of care in the outpatient to really 5 days a week, and we don't have that capacity in most mental health clinics that we could see somebody in an effective format in groups 5 days a week. So I'm not saying to silo everybody for treatment. What I'm saying is sometimes when I'm deciding what needs to happen with the individual, where would they best be served, sometimes the answer is chemical dependency treatment that can address the co-occurring disorder as well. Hopefully that answered the question related to siloing treatment. What I try to do is provide integrated treatment in mental health clinic, but I need to be aware of what is within the scope of my competence as a clinician, and also what is in the scope that the clinic can truly provide, and can it meet the individual's needs. I hope that clarified things. If it didn't, if you could chat in the chat box and we can talk about that a little bit more. So back to the stages of change in motivational interviewing. How do I help people kind of move through the process? To me, stages of change and motivational interviewing, they go together like peanut butter and jelly. So when we were putting the slides together, it was really hard, and there was discussions about which should we put first. Should it be motivational interviewing first or the stages of change, because I use motivational interviewing to figure out what stage of change the person's in. And so what we decided is we're going to try to integrate the two together, because for Lydia, Kara, and myself, really we felt like they kind of partner together, and it's a nice marriage if you can use the two together. And if you want more information specific to motivational interviewing, we do have 2 prior webinars that are going to be available on the website on motivational interviewing. And so I basically wanted to give you really a very brief idea about the 3 components of change, and it's really for motivational interviewing, but really it's in line also with the stages of change. So before any change can be made, 3 things we need to figure out is willingness. Is the person willing to change? Do they want to change? We also have to figure out their ability, okay? Do they have a sense of confidence that they're going to be able to make the change? And then also the readiness, okay? And really the readiness are they ready to make the change right now? And a good example I can give you is, gosh, now it's 4 years ago. I love Diet Pepsi and regular Pepsi and Diet Coke and regular Coke. And I gave it up 4 years ago. And I used to drink it like literally every day. And so for me, I knew like I was willing to give it up, and it was really a process for me giving up the Pepsi. And now this January, I think it's going to be actually 5 years since I've had any soda. But there's many components to change. I didn't just wake up one day and said, I'm giving up soda, that's it. What I did is I tried to figure out, okay, I do love the taste of soda, especially with any kind of junk foods. Sorry about that. I needed to change the slides a little bit. So realistically, I like to drink soda with junk foods. And so really it was a process. I needed to decide, was I willing to change? Did I have the ability to make the change? And was I ready? And really, in terms of motivational interviewing, here are some pretty standard principles, and really they're pretty person-centered as well. So you're going to express empathy with people, the individual, really understand their viewpoint, and validate their viewpoint. You're going to try to develop a discrepancy. You're going to roll with the resistance, and you're going to support self-efficacy. And so what I mean by roll with resistance is a lot of times, sometimes what happens when somebody comes into clinic and they're using a substance and we think that it's causing them some harm and it's substance abuse or substance dependence, what we'll have a tendency to do is kind of hit that right on the head, and then we have a tendency to maybe start butting heads with people. And so what happens then, I kind of think of it this way. I can't remember an argument I've ever been in my professional or my personal life where the argument was productive and people left feeling like this is really great. And so for me, really the role with resistance is the more we ask the person to explore both the positive and the negative aspects of their use, the more willing they're going to be able to look at things, okay? But if I only focus on all of the negative consequences associated with the use, what has a tendency to happen is the adolescent and the individual is just going to try to talk to me about all the positive things, because really it's about ambivalence. And then some more techniques, open-ended questions. I'm big on that. Affirmations, I understand what you're saying. I know that's the way you feel. Doing reflective listening and summarizing. Really paying attention to what you're paying attention to. When we're working with adolescents, we do this all the time in mental health clinic, okay? We want to hear what the person says, and we really are careful what we ask questions about and what we focus on. And motivational interviewing is saying, yeah, you should do that same thing, and you pay attention to what you're paying attention to, okay? Somebody had asked, am I familiar with Teen Intervene? It's a brief intervention method. Yes, I am. It's an evidence-based practice, and it also is appropriate. I think you could use it in doing co-occurring treatment for adolescents in mental health clinic. I believe it's about 5 sessions, so that might be something you want to look into. And so I wanted to spend a little bit of time talking about the stages of change. And really the stages of change say in making any major life change, you go through these phases. And if you want to be helpful, our job as the clinician or the therapist is help the person to move through the stages. And so there's pre-contemplative, and what that means is the person's not even thinking of a change because there's no problem. Contemplative is they're on the fence. Maybe there's a problem, maybe not. Well, yeah, maybe there is a problem. You know, it causes these problems for me, but I'm not really ready to stop using yet because all of my friends smoke pot too, and then what am I going to do? I'm going to be lonely. So they're kind of on the fence and contemplative. In preparation, yeah, you know what, I really do need to make the change, but I need time or a plan. Action, I'm putting that plan into place, and I'm doing what I said I would do, and I'm walking the talk, okay? And so the idea with stages of change in motivational interviewing is you want to use intervention based on the individual stage of change. Earlier in the webinar, what I had said is, well, if we send somebody to chemical dependency and they only want to cut down on their using, one of the first couple sessions is going to be, okay, so when are you going to immediately stop using alcohol or weed? Because there is no harm reduction in chemical dependency, it's abstinence, okay? And so the luxury we have in mental health clinic is we can do a harm reduction. And so if you approach somebody and you use interventions based on their stage of change, you're going to help them move. So in pre-contemplative, don't ask them to make a change. What you'd want to do is ask him or her to explore the use. Well, could we talk about it a little bit? Does it make sense that we spend a little bit of time talking about how your parents are concerned related to your use? And really reaffirm, because the bottom line, the choice of changing is the adolescent or the individual we're working with. It's not ours. So in the contemplative, this is where they're like, well, yes, maybe there's a problem, but it's not that bad. They're on the fence. You want to start talking about cost-benefit analysis of their use. The reality is you have to be comfortable acknowledging all use has a benefit. What I mean by that is the person's doing it for a reason, getting something out of it. And so if I choose just to focus on all the negative, the adolescent I'm working with is going to catch wind of that pretty quick, and then all they're going to talk about is all the benefits. What I want them to do is I want them to talk about both. And I also want them to think about what are the pros and cons of changing, okay? I'm working with a 16-year-old girl. She smokes marijuana. She smokes, maybe once a week, a couple hits off a blunt. Am I going to refer out in that case? My answer to you is probably not. What I'm going to start doing is figuring out where she is in the stage of change and ask her to start looking at that. I'm going to tax her starting at the beginning, so it's normal, and it's just a measure. When I do my tax results, what I don't do is, when I give the results to the person, I don't say it's dirty or clean. Those are judgments. I say it's either positive or negative, okay? Now, if you have the same 16-year-old girl, I have a great scenario. I just talked with one of our child psychiatrists about this. She's being treated for anxiety and trauma. And she smoked marijuana, and so the psych's talking to me about it, and I say, And at that point, it doesn't increase her mental health symptoms. At that point, I'm like, ooh, yeah, I'm not referring out for this. Then the psych said the sentence that changed my clinical thinking, well, there was at least a month to 2 months where she was using Oxycontin every day. Now, for me, I know that typically you don't use Oxycontin every day for a month or two and then just decide, yeah, it's not going to work for me. And so at that point I said, well, we're going to have to get some taxes and really figure out and look at this case a little closer with that. And so for me, it's really about the risk associated with that. And then for preparation, you want to help the person develop the plan. Action, you're going to provide the support. I see my role in preparation and action is, well, what if this happens? What's the solution going to be to that? Okay? We have a few more minutes, and I'm sorry, it seems like we ran out of time rather quickly today. And we're going to have some time for some Q&A, and I'll talk a little bit more about the Teen Intervene program, because another person asked a question about that. And there's some more information for you about how to elicit and support change talk. Again, you want the person to talk about both sides of the coin. If you only talk about that they should stop using and all the bad stuff, they're only going to talk about all the good stuff. And so if you allow them the opportunity to talk about the good stuff, they'll also have the opportunity to talk about all the consequences. And then how do you know if you're using the appropriate intervention for the stage of change? The individual feels supported. There's no headbutting. There doesn't feel like there's a power struggle. And if you're getting a lot of resistance, you're probably using interventions for a later stage of change. So step back a little bit and go back to the open-ended questions, go back to the pros and cons, go back to having them explore their substance use. because at the end of the day, what we want is the decision to come from the adolescent that they want to stop using rather than that we think that they should stop using. And through that, you're going to give them education, and that's a piece of motivational interviewing, that you're giving them that information and education. But they need to feel engaged with you, that you respect them, and they feel supported.
Great. Thank you so much, Julie. We do want to save some time for a couple questions that have come in, but I did want to go back a couple slides that I think there was, they seem to have gotten stuck. So I just want to make sure you saw them, but everybody's going to have both the PowerPoint slides as well as the webinar recording that you'll be able to download, including the KJADE and the screening tools off the ctechny.com website. So I think first point, I think, Julie, which was really important, was these factors to consider when working with adolescents with co-occurring disorders. And I think the message here is really that you can attend to some of these issues in more traditional mental health clinic treatments, but you have to take into account these risk factors and whether it is something that is really safe to do, and do you have the resources, especially if they need much more intensive treatment, like daily types of contacts, in the way that Julie had mentioned for some clients. But other clients, it is something that can be beneficial. And the research is really pointing to integrating treatment, that the best way and the best outcomes are really when you are able to attend both simultaneously, the mental health as well as the substance use issues. But I did want to show this slide in particular that Julie had mentioned, because I think this one wasn't shown, it got stuck, I think, in the system, was these three components of change, that we're talking about willingness, ability, and readiness, and that each of these three areas, and here you have some questions that you can ask using kind of either a scale or some other types of questions, open-ended questions, to kind of help you assess where they are in terms of willingness, where they are in terms of ability, and where they are in terms of readiness. So we do have a few minutes to answer any questions that you have. Please submit them again through the bottom right in the chat box. We have a couple that have come in, and I think the first one was, what is that evidence-based treatment that was mentioned? So that came from one of the participants who had mentioned teen intervene. And then the question is, since it's a brief intervention, is that something that we can do pretty easily in our mental health study? Julie, if you're familiar with it, before we refer them out.
Absolutely. It is, I believe the first 2 sessions are individual, and then it can, I want to say it's no more than 5 sessions. It might only be 3, and you can either do it in the context of individual sessions or a combination of individual and group. It basically is a nice program, and it gives you step-by-step what you need to be covering in each session. So you could absolutely do that. I think that is a good program that would make sense. There's also Motivational Enhancement, MET. They had, I believe it's 5 sessions, and I have the information related to that I might be able to give to you if you wanted to post it. And again, it really is the interventions you can use in clinical sessions in mental health clinic to treat a co-occurring disorder, absolutely.
We also have another question around parents and parents who want to do at-home drug testing with their kids. How do you normally deal with that, and is that something that's recommended?
I can't speak to whether the literature recommends that. To me, it's not recommended because there's so many variables. Number one, so now the parents are like the urine police. You can have, so then, in chemical dependency, some of the urine toxins I do are observed. So am I going to watch my 16-year-old daughter pee in the cup for me before I tox her? I think it just brings other pieces into play. You also have to worry about whether or not they're accurate. I think that if you wanted to do that, I think it would make more sense for the parent either to have it done through the pediatrician office. And then what are you going to do when you get the results and they're negative, but you still have that gut something's going on with your child? For me, I think there's other more effective ways to work with the parent and the child than to do the at-home urine test. There's way too much question mark for me, and then I don't like the way it feels. Are you then going to breathalyze your child at home?
Okay. And that, I think, goes in line with another question we received that says that they find it difficult to balance between the issue of safety, such as, you know, informing parents and referrals, and therapeutic alliance. How do you attend to that issue?
Absolutely. For me, it starts at the first visit that I tell people, if I have a referral source and they sign their release, the adolescent signs a release and the parent signs a release, this is the bottom line. I tell them right away, this is exactly what this means. So if I do a urine test and it is positive, I'm going to need to let people know. However, the urine test just means the substance was in your system, and really what I would want to do is work to develop a plan when that happens. Rather than, and so for me, since you put that right out there in the open, and I start that right at the first session, I do urine tests and you sign a release for probation or PINs or the law guardian, you know that I'm ethically obligated. Now I'm taking kind of the onus off me that it's my decision. It's not my decision to give those results. I am ethically obligated because you have signed a release that I need to give those results to your referral sources. But let's talk about, if you had a positive, the process that you'd be comfortable with. And that's how I address that. And again, I think it's also a decision also with the parents to get involved, because if Sally comes in and she told me she drank a beer on Friday, I'm not going to call the parent right now, oh my God, Sally drank a beer. Because then Sally's just going to stop coming in and saying she drank a beer. So for me, it's a decision and a discussion with the parents about, when I really have some concerns or health concerns or safety concerns related to use, then we'll be talking about that. Otherwise, if I need to inform you every time Sally drinks a beer, she's just not going to tell me anymore, and we'll have no idea what's going on. When it's clinically significant, I bring it to you, and I think that, to me, feels better and is more natural with parents.
Thank you, Julie. I think we can answer one more question, and I'm going to get to, somebody also asked about the CUs. I'm going to get to that right after Julie answers this last question. Do you ever get any resistance from the insurance companies about licensure and training related to substance abuse? Meaning you're not licensed to treat that, you must refer out. Any resistance around attending to both issues in mental health clinics that you've experienced?
Well, honestly, I get a lot of resistance from insurance companies related to, it's not necessarily the substance use, it's related to they don't want to pay for groups in mental health treatment. So in order for me to get a group approved now through some Medicaid managed cares, I have to fill out this entire group roster about exactly what clinical interventions, what are the specific diagnoses. So for me, we speak to, because our clinics, we have kind of two levels of clinicians, both in my mental health and my CD clinics, okay? Everybody has a minimum training standard. The expectation provided through the agency is you have to be able to effectively assess and screen for a substance use disorder in mental health or mental health and chemical dependency, and I use a screen that is valid screen in both clinics, okay? Then I have specialists, and the specialists have taken additional training and they have an expertise in the treatment of co-occurring disorders. So I don't necessarily get a lot of resistance that you're not licensed to treat that. I'm not licensed to treat chemical dependency in mental health clinics. That is true. I am licensed that I am allowed to treat a co-occurring disorder. And a great way to get the training and the expertise you need to provide treatment of a co-occurring is the Center for Practice Innovation through Columbia University. They have a fully integrated treatment. There's about 30 hours of module training that are free, and so all of our staff get trained on that. So when I'm speaking with the insurance companies, I also speak to that as well.
Great. Thank you so much, Julie. So I just wanted to point out there's a couple of questions coming in around what are some of those treatments that were mentioned, and one was teen intervene, the other one's motivational enhancement therapy. And here we have a list of additional resources. If you look at the bottom link on the page, the co-occurring disorders review, that is a review around kind of the state of the evidence on co-occurring disorders in adolescents, and they also list the different evidence-based interventions that have been developed so far. And it really is sort of an emerging area because there are only a few that are really shown to be rather promising. And if you go to that review, you're going to see a listing of what those are, and and it has information on how to get additional information on each of those specific interventions. Here's a listing of the references that we've mentioned throughout the webinar. If you're interested, you're welcome to kind of look at those as well, especially for some of the current research in the area. You're welcome to contact Julie if there was a question that wasn't answered, or if you have additional questions after the webinar, feel free to contact Julie Gutowski directly. Her information is also listed on the ctacny.com website under the CTAC team bios. We have 3 upcoming lunch and learns for October. It's our Integrated Health Month, and we'll be covering things like behavioral health medical homes, collaborating for health, attending to culture, spirituality, and community and decision support tools. To get some more information about our October lunch and learns, please go to our website, ctacny.com. And last but not least, today's webinar is approved by the NASW New York State chapter for 1CU as part of their continuing education recognition program. If you would like the attendance verification form, please email me directly at lmf234@nyu.edu, and I will send that form directly to you for those who participate and attended the online live webinar. Thank you, everybody, for participating today. I hope you have a wonderful day. Take care.